So good afternoon to all our speakers, panelists, and attendees from MENA area. On behalf of Professor Dr. Fadi Farahat, the President of Cancer Research Group, and myself, representing AMAC, Arab Medical Association Against Cancer, we are welcoming you in our activity of today about updates in diagnostics and management of advanced ovarian cancer. As you all know, these activities are endorsed by AMAC, UICC, and ASCO. It's awarded by 2 CMEs, and it's translated to French simultaneously. So anyone would like to hear the lecture in French, so he can do it. I'm welcoming all of you. We have today as a panelist Dr. Faisal Azzam and Dr. Imad Hassan. So Dr. Faisal, the floor is yours to present our speakers and to start our activity. Please, Dr. Faisal.
Thank you very much, Dr. Khatib. That's very nice of you, and I'm privileged to be panelist in this important meetings.
Thank you, Dr. Faisal. So as usual, our quiz, we start with it, and the module is about GYN cancers. This is the question, which of the following is accurate regarding recommendation for cervical cancer screening? Women aged 21 to 30 years should undergo annual screening for cervical cancer with HPV testing alone or in combination with cytology. So this is the first one, A. Initial screening for cervical cancer in women should begin at age 19 years. Screening for cervical cancer with cytology, pap smear, every 3 years is recommended in women from 21 to 65 years. Women who have had a hysterectomy with removal of the cervix and who do not have a history of high-grade precancerous lesion of cervical cancer should still undergo annual cervical cancer screening. So there is only one response, one good response. Please choose either A, B, C, or D. Regarding the USPSTF recommendation to cervical cancer screening, what is your decision? Since we have a session concerning the cervix presentation, so we have 46% telling us that C is the right answer. And in a similar questionnaire, this is what our colleagues answered. So 77% approved the C response, which is the right one. And you can debate it later on if you want.
Vanessa, please, would you like to allow speakers and panelists to answer the questions?
To vote. Okay. I'm drinking coffee now. So the second question doesn't concern me, but it's interesting. Coffee consumption has been most strongly associated with reduced risk for which of these cancer. So the coffee consumption will reduce the risk of cancer in which situation? In non-Hodgkin lymphoma, endometrial cancer, bladder cancer, AML, acute myeloid leukemia. I found it nice when I was reading, so I've put it as a question. Coffee consumption has been most strongly associated with reduced risk for which of these cancer? Okay. 74%, that's what I said, it doesn't concern me. 74% voted for endometrial cancer, and indeed 61% for our colleagues answered that it's bladder cancer. Usually we know that for bladder cancer it increased, here they reduced the risk. So the answer for our colleagues was 61, but if we look to the data, we will find that a review of 28 meta-analyses found that coffee consumption significantly limited rates of endometrial cancer. That's right. So that's what was 74% answer that, and was characterized by a dose-response relationship. More moderate inverse association have also been reported between coffee consumption and the risk of developing ER negative and postmenopausal breast cancer, melanoma, basal cell carcinoma, oral cavity cancer, pharyngeal, colorectal, and prostate cancer. So there is a moderate inverse association with the coffee for this cancer, and there is a reduction, considered a reduction for endometrial cancer for the coffee consumption. There is an Italian study found that consumption of more than 4 cups of coffee per day increased risk for lymphoma, particularly for the follicular subtype. And all the study found an association between coffee drinking and increased risk for bladder cancer. We'll not go through that, but it's well known that also the way that how we prepare the coffee is most important. In our region, it creates bladder cancer, it stimulates bladder cancer because of the way that we prepare it. Japanese study found no significant association between coffee consumption and the risk of acute myeloid leukemia. So the right answer was endometrial cancer. Question number 3, we have a talk, a nice talk about fertility preservation. So what are the options of fertility preservation for females? Is it egg or embryo freezing, ovarian tissue freezing? Is it ovarian suppression or ovarian transposition? Is it ABC, which means a freezing, egg, embryo, ovarian, and suppression, or is it all the above, A, B, C, D? So fertility preservation option for females. All of the above, or we had egg embryo freezing 35, and all of the above 65%, and the right answer is all of the above. Now a question about HRD. Thank you, Dr. Wafa, for your presentation that we will have, because I think it's a nice topic. What to know about homologous recombination deficiency HRD testing for ovarian cancer? HRD is a biomarker present in most advanced stage of ovarian cancer, and its presence can help predict high-grade ovarian cancer and help guide treatment. This is the A statement. The B statement, DNA damage repair occurs through different pathways. One of these is HRD. The 3 genetic mutations, specifically the mutation of BRCA1 and BRCA2 genes, sorry, it's a typo error, BRCA2 genes, have been recognized to cause 10% of ovarian cancer. The D option, these mutations, along with other genetic abnormalities, affect the HRR pathway, prevent the body from producing proteins that help repair breaks in DNA. This leads to an accumulation of mutations that can lead to cancer. So is it A or B or C or D, or is it all the above? Please give time to, yeah, all the above, 86%. So, and again, it's the right answer. And, oh, sorry. So it's the right answer, all of the above. And our last question, since we are starting with Dr. Wafa, HRD can be determined by BRCA1, BRCA2 mutation, genomic instability, MSI, TMB, and PDL1, PD1 expression, A or B, or all of the above. So how can we determine the HRD mutation? The HRD, sorry, the homologous recombination deficiency? Is it by the BRCA1-2 mutation? Is it by the genomic instability markers, which include LOH, LST, and TAI, or is it by the finding of MSI, tumor mutational burden, microsatellite insufficient, and PD-1 programmed death 1, programmed death L1 expression, A and B, or all of the above? Please vote. So A and B 55%, all of the above 30%. I think it will be explained later on. BRCA1, BRCA2 mutation, it's right, it's good. 10% for genomic instability, yes, it's right. MSI TMB 0%, it's totally right because it has nothing, it's not related to the BRCA, to the HRD homologous recombination deficiency, and A and B is the right answer. So with that, I will stop here, and it's an introduction for the next presentation. Please, Dr. Faisal, the floor is yours. Thank you very much.
So today we have 4 presentations. The first one will be by Dr. Wafa Abu Alanin, who's a clinical scientist in diagnostic genome division at Hamad Medical Corporation in Qatar. So she's going to talk about the HRD testing and its importance and how it will improve the molecular diagnostic services for breast and ovarian cancer. So Dr. Wafa.
Thank you very much for the introduction, and thank you, Dr. Fadi, for arranging, and Dr. Sami for arranging this educational meeting. It's always a pleasure to be part of it. Let me start by sharing my screen. Okay, I will be going in the coming few minutes to talk about improving the molecular diagnostic services for breast cancer, as well as ovarian cancer, and the importance of implementing HRD testing. I will start by giving just general definition of cancer. Cancer is a collection of disease characterized by uncontrolled cell growth or uncontrolled cell cycle. Cancer cells can divide rapidly and evade the protective mechanisms that can kill abnormal cells and cause metastasis. Also, in the past years, we start hearing additional definition to cancer by considering it as a genetic disease or disease of genome, which is generally characterized by changes from normal cells to cancer cells caused by series of somatic mutation. And what we mean by somatic mutation is the DNA changes that caused at the time of cancer development or cause cancer to develop. In addition, presence of germline mutation, which are inherited or raised on the germ cells, the presence of these mutations will increase the risk of developing cancer. From here, I will go to the main points that I will be covering in this presentation. I will be giving just quick background of breast cancer and its risk factors, DNA damage response, DNA double-strand breaks. Also, I will try to cover the homologous recombination repair and its related pathway and its deficiency, the methods that we can use, and the clinical impact of HRD. Talking about the breast cancer is a form of cells that raised on the breast. It can affect both male and females, more common in females. Breast cancer survival rate have increased in the past years, largely due to factors such as early detection, I can't see the whole screen, sorry, and the new personalized approach to treatment and a better understanding. The risk factors of breast cancer And many of these factors that I'm presenting here also are shared with the ovarian cancer, such as obesity, increased age of the patient, and some physiological changes that can affect the woman or the ladies, such as the age of period, the starting the period, age when some other physiological changes happen, like menopause, having children or never been pregnant, exposure to hormonal therapy, alcohol drinking can also be related to breast cancer or other cancers as well. Radiation exposure, some conditions that affect the breast, like any other diseases that cause the patient to be exposed to biopsies, can also be a factor to increase risk for breast cancer. Personal history of breast cancer or family history of breast cancer can be a factor as well, will increase the risk. I will mention here also the inherited genes that are increasing the risk, the known genes that causing breast cancer, mainly the BRCA1 and 2. I've mentioned here the inherited genes as a risk factor because here, this is the germline mutations that I spoke about at early, because most of the cases of the breast cancers are raised due to somatic accumulation of somatic mutations, but the presence of inherited genes can cause mutations in related genes can increase the risk, is a risk factor. So for the inherited breast cancer, 5 to 10% of breast cancers are linked to gene mutation passed through generation of a family. A few inherited mutated genes can increase the breast cancer. The most well-known are BRCA1 and BRCA2, and both have significant increase the risk of both breast and ovarian cancer. If having a strong family history or other cancers, blood test is recommended to help identify specific mutations in BRCA and other genes. This is basically to identify if the cancer is inherited. And definitely, when inherited mutation is identified, the consideration of genetic counselors is strongly recommended and must be recommended for the patients and for the follow-up for the high-risk family members. Talking about BRCA1 and BRCA2 genes, because they are the most involved in this cancer type, BRCA1 and 2 play a role in the process of DNA repair as part of the DNA damage response pathway. So the DNA damage, we have several ways to pathways for the repair of the DNA and to respond to it. For the double strand break or single strand break, there are also sub pathways that are playing role. In our situation, talking about the homologous recombination is one of the like genotoxic, the highest, the most genotoxic pathway. And the main player here, gene is genes BRCA1 and 2. And the other pathways are not our interest for today. But I would like to mention here that the main player for the single strand break is the PARP enzyme, the base excision repair. This I will come to it later, but our focus for today's presentation is the DNA damage response by the double-stranded break DNA by the homologous recombination. This is the same information in different representations, just to show that for the double-strand break, there are so many players, and the main player is BRCA gene, which after the BRCA perform its function, the DNA will be repaired. Talking about the homologous recombination repair, there are several genes involved in HRR, or the homologous recombination repair pathway, including BRCA1 and 2. When there is a DNA damage in the double strand, these proteins are working together to repair the break in the genome. And this will end up by repairing the breaked double strand and ending up with repaired genes, and it will preserve the genomic stability. But sometimes these genes have mutations. They are unable to perform, they lose their ability to perform the repair, the HRR. What will happen? The cell will choose other pathway to maintain its genomic stability. So this the cells with malfunctioning HRR rely on error-prone pathway, other pathway, such as non-homologous end joining. It will be by different group of genes, and will end up by repairing the DNA, but it will not be stable. It will still generating like weaknesses, let's say instability. When I mentioned here some of these genes that can not performing well, resulting in producing unstable DNA or making the cell shift to other pathway, what type of mutations I'm talking about here? These mutations or genomic alterations can be a substitution, changing one nucleotide to another, or small deletion, like if this is my reference DNA, some of the nucleotides will be removed, deleted, or small insertions, such as inserting few nucleotides compared to the normal reference. Also, what other mutations or other alteration can affect the gene function? Promoter methylation, which will cause the gene to be silenced, and the protein might not be produced to perform its function. The other mutation that can be happen, copy number variation or copy number alteration. If we have here my normal alleles, in tumor cells, I either have some part of the allele will be deleted, or some copies will be more, or maybe the whole allele will be copied. So I will have 3 copies, maybe 5 copies of certain place or chromosome. So these are some examples of alterations that can happen. Looking to this statistical presentation of possible HR genes alteration, we can see that most of these genes well studied by BRCA1 and BRCA2 for both germline and somatic. So they are the biggest studied genes and the biggest non-related genes, including somatic mutation, germline mutation, as well as promoter methylation. Some other genes related to the DNA damage also are included. We can see also other related genes, I would say, and some of them still under research maybe, or still unknown. When these genes lost their ability to repair DNA, and result in genomic instability, this phenotype is called homologous recombination deficiency, which can be caused by, as I say, the BRCA genetic mutation of other genes, promoter methylation of BRCA and other genes, and the huge, still undetermined causes. We are still investigating these. The researchers, scientists, everywhere, they are looking for this, but it's still a huge chunk, but at least we have some known causes. This will result in instability to repair the DNA and resulting in genomic instability. Inability to repair the DNA and result in genomic instability. What is the genomic instability we are talking about? How the genes will be unstable? So this we can, based on that, we can see that there is a loss of heterogeneity, LOH, by presence of a single allele. Also, a telomeric allelic imbalance, where we can see the telomere part of the chromosome maybe is lost, or we can see also larger scale state transitions. And this is between the regions, we can see between regions compared between the two alleles, causing abnormalities. So how can we detect these mutations, and how we consider the genomic instability, how we test it in the lab? For detection of HRD, there are two principal approaches to detect tumors with HRR capability and association of HRD deficient phenotype. There is a gene panel using NGS by HRR genes, by sequencing the genes in the HRR pathway, related pathway, to look if there is any abnormalities by sequencing, direct sequencing, including the BRCA1, ATM, the CHEK2, and other genes. Or we can study also the sequencing with the instability assay, together with the instability assay. And this is called SCAR test. It's a quantitative assay that results in characteristic of studying the HRR capability and characteristic of HRD phenotype. In this assay, it will also include the LOH, TAI, and the LST. The SCAR test, it has like two phases, let's say, or frontline test, and based on the outcome, additional tests will be considered. So the first step is the detection of BRCA1 and 2 status, to look for sequencing and for the rearrangements, if there is any rearrangements. This detection and classification of the variant and the rearrangement identification of somatic and germline within these two genes. If it is positive, many labs consider that this information is enough to consider the status of the patient. If it is negative, then they consider including the testing of the genomic instability status. The guidelines, there is no, to my knowledge, the guidelines is changing so fast regarding the HRD testing, and it's different from one lab to another. The genomic instability status, it has a special comprehensive assessment for the loss of heterozygosity, telomeric allelic imbalance, and the large scale state transition. And it will be given like a score to determine the HRD status for the patient. Based on that, when it is started, the the testing for HRD, it was limited across the world. I think now more labs are performing these tests. The first lab generated this was the My-Choice Myriad Genetic. They invented this procedure, let's say, and they did, it got FDA approval as well for determining the BRCA and the 3 instability status for the genomic. Based on the results, the testing will be, the targeted therapy will be considered for the patient. I think my colleague will be covering the treatment for a targeted therapy of the patients later on. And also foundation one, the foundation medicine, they have different way from testing. They do only sequencing. They don't include the instability measuring. And based on the outcome, they consider the treatment for the patient as well. And both were FDA approved. Talking about the enzyme that is involved in the procedure for a single strand break, as I mentioned earlier, was the PARP enzyme. The PARP enzyme can be blocked as a target as a therapy by using PARP inhibitors. And the mechanism of using this is by blocking the ability of the PARP to repair the DNA, resulting in high mutant double-stranded breaks, high mutant DNA, which will make the cell escape and die, causing cell death. And like any other targeted therapy in different cancers, we usually give treatment. Later on, we will find that there's resistance. Resistance can generate it after some time of treatment. And this is also happening when patients are treated with the PARP inhibitor. Whether by secondary mutations in BRCA genes, or also it has been loss of function of TP53. All the PARP was not inhibited for some reason. And these 3 mechanisms up to now have been observed to cause resistance to the treatment. With this, I reach to what is the clinical impact and the importance of HRD testing. It says that the assessment of HRD is an important prognostic and predictive biomarker. Accurate detection of HRD is a clinical relevance, and it is in the activate. What is this? I cannot read it. It is important.
It's indicative of sensitivity.
I have a broken screen. I can't read everything written here. Sorry.
Do you want us to read it, Wafa?
Well, I have problems with my screen. Even many of them, I was guessing what I'm saying.
I can go through it if you want me.
When there is figures, I can follow better. But when it is only something written, I'm lost.
This was wonderful, actually. Wafa, this was excellent. It was really explicitly.
I'm very sorry for that.
Not at all. No, not at all.
I will just mention what I can from my preparation. That this is using PARP inhibitor is very important, not only in breast cancer, but also in other cancers like prostate, like ovarian and pancreas. We also, as I mentioned, testing the patients for BRCA is important. Also the hormones, the status of the hormones with the patients will also help in decision. like estrogen and progesterone. And this also will make a decision for using the PARP inhibitor. BRCA testing is not the only important test to determine the targeted therapy. It is beyond that. Many other genes are involved, many other alterations are there. And I think with that, I came to the end of my presentation.
Thank you very much. That was
if there is anything else written, I'll keep this on the screen.
We will have 10 minutes of discussion. I hope there will be a lot of questions, but you really explained it very well. The HRR pathway, HRD testing, very explicitly explained. Thank you very much. This was very nice. I enjoyed it personally. And the last sentence was really good. The clinical implication of it, you said, but our colleague, Dr. Joseph Katan, is going to talk about the clinical implication of the HRD testing probably. So he will talk about to strengthen the frontline therapy in advanced ovarian cancer. He's a president of CME office at the Faculty of Medicine at St. Joseph University, University of Beirut in Lebanon.
Thank you, Dr. Fadi Farhat. Thank you, Dr. Sami Al-Khatib, for allowing me to present the latest in frontline therapy in advanced ovarian cancer. So I'm talking about the maintenance therapy and the role of PARP inhibitor after first-line chemotherapy in ovarian cancer. I will start with a short introduction, then talking about the studies and ending by the recommendation. I will start talking about the disease itself, the ovarian tumor. The problem of the disease is the majority of diagnosis done at advanced stage. And at diagnosis, we have at least 60% or even more who are diagnosed at advanced or locally advanced stage. And once we have advanced stage, the survival will decrease. Here we have almost 30% 5-year survival when the disease is diagnosed at advanced stage. And if we look to the natural history of ovarian cancer, we know that this disease is platinum sensitive. So at diagnosis, when we start with the chemotherapy, we will have some kind of response, and we have a response, then there will be some progression-free survival time, then there will be a relapse. So second time sensitive to platinum, we will treat again, but we will have a shorter PFS, and at the end, we will end up by 70% of these patients will relapse within 3 years. So here in this slide, I have the reduction of PFS after each line. We started by around 10 months, then 6.4, then 5.6. So what we need really, the unmet need, is to have a maintenance therapy that allow us to prolong the progression-free survival. Meanwhile, 10 or 15 years ago, we understand one of the main mechanisms of the DNA repair. It was the PARP enzyme involved in repairing single-strand break repair. And also, we discover what we call the PARP inhibitor. The first one who was in the market was Olaparib. The PARP inhibitor will block the reparation of the single-strand break, and this single-strand break will accumulate, and it will be lethal when we don't have what we call a backup reparation. So at that time, that the only mechanism of DNA damage accumulation to repair the double strand that was related to BRCA1 and BRCA2. And now you are I moved my slide. Are you seeing? And
yes,
we know at the time that the frequency or the prevalence of BRCA mutation, either as germline or as somatic, it's present in only 20 to 25% of ovarian cancer. But also, we know that if we look here to the right, we know that the majority of the BRCA mutation are not related to the family history. We have BRCA mutation in 60% of patients without family history. Based on that, in 10 years ago, in 2012, there was the idea to test the PARP inhibitor, the Olaparib, the first one in the market, versus placebo in patients with ovarian cancer who relapsed. So these patients are relapsing patients, they still platinum sensitive, and after the response of chemotherapy, they were randomized 1-to-1 to receive either Olaparib or placebo. And the primary endpoint of the study was PFS. They look retrospectively to the mutation in this population, and they found in 71 of these patients, there is a BRCA mutation, either somatic or germline. And they analyzed the primary endpoint. The primary endpoint was met. The PFS was better in patients who receive Olaparib versus placebo. And the hazard ratio was 0.35, and the median PFS increased from 4.8 to 8.4. They also look to the part of patients who have BRCA mutation, and they found that the benefit was more important, and the median PFS for the Olaparib arm was 11.2, and for the placebo, it was 4.3, with a hazard ratio of 0.18. Very important response in refractory patient with Olaparib. They also look to the other part of the patient who don't have a BRCA mutation, and even in patient without the BRCA mutation, they found there is a difference, a significant difference in progression-free survival in favor of Olaparib, with a median PFS 7.4 versus 5.5 for the placebo, with a hazard ratio of 0.54. Then there was a lot of other studies published, either with Olaparib or with Niraparib or with Rucaparib in multi-treated or in relapsed ovarian cancer. And all these studies showed a benefit in progression-free survival in favor of the PARP inhibitor compared to the placebo. And we know now that Olaparib, Niraparib, and Rucaparib, they all were recommended or licensed in patients who are relapsing ovarian cancer following a salvage therapy with platinum sensitive, irrespective of BRCA mutation. So with or without the BRCA mutation, the PARP inhibitor are indicated in advanced lines for maintenance in ovarian cancer. Now, meanwhile, they understood of the mechanism of homologous repair of the DNA was more understood. And we know now that it's not limited to BRCA1 and 2 mutation. as Dr. Wafa mentioned, there is a genomic instability that look for the LOH, the TAI, and the LST. And we have, based on the genomic instability, a score that goes from 0 to 100. When it is more than 42, that means we have a genomic instability. And if we look to the data that we have now, the BRCA1, BRCA2 mutation as a prevalence are around 20 to 25%, but the HRR deficiency or HRD is around 50%. So it's not limited to BRCA mutation, but it also involved other genes like CDK12, FA, the family of RAD, the MC, the P10, and we end up to find an HRD positive in 50% of ovarian tumor. So let's go back now to our ovarian cancer in first line. We know that also in first line, we have an unmet need because we have only a PFS around 1 year, 15 months when we are giving platinum-based chemotherapy. And if we look to the old literature, I'm not moving now. The slides are not moving. Okay. When we look to the old literature, to the left, for instance, we found a lot of trials done in the past trying to increase the median PFS by adding high-dose platinum, triple therapy, dose dense intensity, and it was a big failure. There was no increase in PFS. The only positive study is in the right, the GOG 218. This study published in 2009 approved bevacizumab with chemotherapy at the beginning, then as a maintenance, and thanks to the bevacizumab, the median PFS increased from 12 to 18. Now, the next slide. Next slide. So now what about using PARP inhibitor Olaparib in first line as a maintenance therapy in patients who are limited or selected as BRCA mutation? This is the title of the SOLOI. The SOLOI study was conducted in 2018 and included only BRCA mutated patients. Why? Because in the study 19 that I presented already, the lowest hazard ratio was obtained in BRCA mutated patients. So the authors at the time included only BRCA mutated patient in the SOLOI. Next slide. This is the study design. We have almost 400 patients included, randomized 2 to 1. These patients are first line receiving platinum-based therapy. They are all germline or somatic BRCA1 mutated, and the Olaparib arm must be given for 2 years compared to placebo, and the primary endpoint was PFS. The next slide. This slide showed that patient characteristics were well balanced between the two arms, especially for the type of histology, for the stage of the disease, and for the frequency of BRCA1 and BRCA2. Here in the bottom, we can see the percentage of patients who are BRCA1, 75 or 70% in each arm, BRCA2, 20%. And there is no patient without BRCA mutation according to the inclusion criteria of the study. Next slide. And here also are the characteristics of these patients according to the residual disease after surgery, even if the surgery was done as upfront or delayed. Either if there is a residual or no residual disease, the characteristics of these patients were well balanced. Next slide. Next. And next. So here is the primary endpoint, the PFS. If we look to the 24 months line at 2 years at the end of Olaparib, we have a huge difference in favor of the Olaparib, and we have as a median PFS 56 compared to 13.8, and the hazard ratio of 0.33. And in 2020, they published the update with a longer follow-up at 60 months, even at 60 months, at 5 years, even after the 3 years of the arrest of the end of the Olaparib, the benefit remained with the same hazard ratio. Also, there was other exploratory objective in the next slide. Here we have the PFS2 was in favor of Olaparib arm, the TSST, time to second subsequent treatment, also in favor of Olaparib arm, but the overall survival is not mature yet. Next slide. Here to show that after the SOLO1, there was other study published. The Paula1 study include all the patients, all the comers. There is no pre-selection of patients according to any gene mutation. So these patients in Paula1 are randomized between Olaparib for 2 years versus placebo. But these patients in Paula1, they receive bevacizumab initially with the chemotherapy, then after as a maintenance. So there is an arm of Olaparib beva versus beva alone. And the second study is the PRIMA study with Niraparib, the same design. Also, there is no pre-selection of patients on chromosome, on gene abnormalities. So they include all comers. And the third study is the Velia study based on Veliparib as the PARP inhibitor. But this study, the third one, the Velia one, I will not discuss it because the design of the study is not very usual. The Veliparib was started with chemotherapy and continue as continuous maintenance. The next slide. Here to show the difference between the SOLO1 and the Paula1. The Paula1, as I said, it includes all the comers, either with BRCA mutation or without, either HRD positive or not. But we have to know that there is a bevacizumab continuous arm in both arms. The next one. The next one show the design of the study. It's a big phase 3, 806 patients included. In the experimental arm, Olaparib 3 milligram for 2 years plus maintenance beva versus placebo plus maintenance beva. And also the primary endpoint is PFS. The second slide, we will show in the second slide the balance of the characteristics of patients according to the 2 arms. The second slide. Also concerning the residual disease, either after the upfront or the interval surgery, they were also balanced. And we move to the next slide, showing the primary endpoint, the PFS, which was statistically in favor of Olaparib. And here we have to the right the median PFS 22 versus 16 with a hazard ratio of 0.59. The next. we analyze the PFS advantage according to this forest plot to the different characteristics of patients. All the subgroups of patient benefit from Olaparib maintenance versus placebo. Next slide. And here we look to the group of patients who have BRCA mutation. Patients among the included patients who have BRCA mutation to the left, they have a higher magnitude of response in PFS with a hazard ratio of 0.31. And if we look to the right, patients without the BRCA mutation, they also have a benefit with a hazard ratio of 0.71. Next slide. Now we look to the patients who are HRD positive, including BRCA mutation, significant difference, median 37 months in the Olaparib Biva versus 17 months in the Biva alone with a hazard ratio of 0.33. Next. Next. HRD positive without the BRCA mutation, also significant in favor of Olaparib Biva with a hazard ratio of 0.43. Next one. Next. And here is the important slide showing that in HRD negative, among these patients, those who are HRD negative, that means BRCA1 and BRCA2 also negative, there is no difference. The hazard ratio was 0.92. Next. Now I move to the PRIMA study. The PRIMA study, it includes all comers, and the drug in the study is Niraparib. The duration of maintenance therapy with Niraparib is 3 years, not 2 years, versus placebo. And the primary endpoint is the progression-free survival. Next. Also, there is a well-balanced characteristics of patients between the two arms. Next. And here we have the primary endpoint. It was the PFS in HRD patients. It showed a significant difference with a hazard ratio of 0.43. The median PFS was 21.9 in the Niraparib arm versus 10.4 in the placebo arm. The next. In the middle, if we look to the Kaplan-Meier curves of the PFS in HRD positive BRCA mutated, also we have a significant difference, but the most important curves are on the right inside. Patients who are HR proficient, that means HRD negative. Even these patients in the PRIMA study with Niraparib, they have a significant benefit. And here we have the hazard ratio of 0.68. So even in HRD negative, there is a room to give Niraparib. Now, the next. Let's have some comparison between the 3 studies. The SOLOI, dedicated only for BRCA mutated patient, versus the PRIMA, all comers with Niraparib, versus PAULA, all comers with Olaparib. There is significant difference in the progression-free survival in the BRCA mutated patient. If I look to the hazard ratio, it's almost the same. 0.33, 0.4, and 0.31. The next, also it's a comparison between the studies. In the PRIMA, for patients with HRD positive, but BRCA not mutated, wild type, HRD without the BRCA, there is a significant difference of 0.5. In the PAULA with Olaparib and Biva, we have almost the same benefit, with almost the same hazard ratio, 0.43. Next slide. And once more, the only difference between PRIMA and PAULA, or in other words, between Niraparib and Olaparib, when we have HR proficient or HRD negative, with the PRIMA, the Niraparib arm still have a significant benefit with hazard ratio of 0.68, but in the PAOLA-1, there is no difference in PFS, either in the arm with Olaparib beva or beva alone. Next slide. Now I arrive to the, not the last one, the pre-last one, with the approval of the FDA. Look only to the first line. Olaparib is approved in first-line maintenance therapy for BRCA mutated according to the SOLOI, and also in combination with beva after first-line patient who get platinum and beva in HRD positive according to the PAOLA-1, while Niraparib, the second line, Niraparib is indicated in maintenance therapy regardless of BRCA or HRD. The next slide. Look, here is an schema or algorithm that play the role of a summary what we are doing now. We start from the left, after the diagnosis of ovarian tumor, we can proceed to the surgery immediately, or we can give neoadjuvant and do a delay surgery, whatever the procedure. These patients at the beginning, they must have a molecular genomic analysis. We have to look to the BRCA, either germinal or somatic, and to test the HRD. And according to the results of the molecular abnormalities, we have in the right 3 scenarios. Either we have a BRCA mutation in around 20% of patients. So here we have to use, or we have the advantage to use as maintenance therapy, Olaparib according to SOLO1, or Olaparib plus beva according to the PAOLA, or Niraparib according to the PRIMA. Second scenario, we have patients who are HRD positive, but not BRCA mutated. These patients can benefit from Olaparib plus beva according to the PAOLA-1, or from Niraparib. And for patients who are HRD negative, we can give beva alone, or we can give Niraparib, because I show you that even in these patients, the Niraparib still positive. And the next slide. Thank you for your attention.
Thank you, Dr. Joseph. This was
and
very
sorry
good.
Once more for the technical problem.
No, that's all. Thank you very much. Thank you very much. That was really good review of the PARP inhibitors. So now we have around 10 minutes of panel discussion. So Dr. Wafa, if you can also please unmute yourself, and so we'll discuss. And I'm not sure if the attendees can put the question in chat or not. If they will just answer those also. Anyhow, Dr. Joseph, I have one question to start with, and then we will see if we have anybody else in the panel who would like to ask the question. Yes. So you give us a lot of trials and you compare different trials. So if you have a patient now with the BRCA mutation, so first thing is, because most of these trials are saying that regardless of BRCA mutation, the benefit with PARP inhibitor is there, yeah? So is there any point of doing BRCA mutation testing now? Or should we just leave this BRCA testing and straight away go for maintenance therapy? This is my first question. Second is, if you have done a testing and it came back as mutant, we have now Niraparib, Olaparib single agent, bevacizumab single agent, or combination with Olaparib plus bevacizumab. Do you have any way of selecting a patient that this patient you will definitely give Olaparib alone or Niraparib alone? This patient will benefit from bevacizumab alone, or this patient will benefit from combination of bevacizumab plus Olaparib as in PAOLA-1. So how would you do the selection of the patient, and also is the BRCA testing really necessary now?
Thank you, Faisal, for this interesting question. If we put apart the prices, the accessibility of drug, if we are living in a health system that can reimburse everything, according to the data and according to the benefit presented by the long-term PFS benefit with the SOLO1 in patients who are BRCA mutated at the diagnosis, we have an obvious benefit with a unprecedented benefit with PFS. So I think in BRCA mutated, with this long experience and long follow-up of these patients, giving Olaparib as a maintenance is justified, even if we don't have yet an overall survival result. For the other part of the question, BEVA, if we don't have the access of any PARP inhibitor, adding bevacizumab to high-risk patient after the surgery and the treatment is a well-known, and we are practicing this state-of-the-art procedure since long time. For the Niraparib, if we look to the results in BRCA mutated or HRD positive, these results are almost the same as the Paula-1. The only difference is the Niraparib benefit, even it's small, maybe it's not really convincing. In HRD negative, we still have a benefit only with Niraparib. So if we have to choose between Niraparib and Olaparib in patients who are HRD positive or BRCA mutated, I think also the results are the same. We don't have the right to compare between studies, but looking to the data, we have almost the same benefit. The only difference, if we have to choose in HRD negative patients a maintenance therapy other than bevacizumab, and we have the accessibility, giving Niraparib, it's not a bad idea.
Thank you very much. That was a very nice explanation. We have a lot of questions actually from attendees. So I'll just go through it quickly, and I think we have only a few minutes. So the first question is from Aisha Muhammad. In patient with HRD negative who started on bevacizumab with chemotherapy, do you prefer to add PARP inhibitor to the Avastin? Dr. Joseph, I think you've answered this. So the question is, somebody who is HRD negative and on bevacizumab, would you like to give a PARP inhibitor, or would you just continue with bevacizumab?
In fact, we have this only data. It's not very solid. The HR is almost 0.7, the hazard ratio. So there is a benefit, but it's not very solid. So saying that this Niraparib must be reimbursed or must be given for HRD negative, it's the only data that we have. We can criticize. Maybe we have to wait for other PARP inhibitors to see their role in first line, because in advanced line, all are positive. In first line, we have to see if there is another data positive with HRD. Otherwise, we can criticize also the study, and we can just giving bevacizumab. According to my last slide, bevacizumab is an option in HRD negative.
I agree with you, actually. So my practice is the same. Those patients who usually present with ascites or pleural effusion, and when I started with chemotherapy, and if they are HRD negative, I just continue with single agent Avastin. I don't add the PARP inhibitor. So next question is, do you think we still need for Avastin with Olaparib in BRCA positive patient? So
I didn't catch up the question. Please, can you repeat, Faisal?
Yeah, so I think the question is, what they're asking is those patients who have a BRCA mutant disease. So would you like to give Olaparib with Avastin? This is what. So you answer this question when I ask you the same sort of question.
Look, we have the answer in the Paula-1.
Exactly, yes.
And we have a very significant difference favoring PFS. So exactly. Also we need maybe more time, more follow-up to be more convenient, but the data is here and it's obvious.
Yes. The next question is, can we use Olaparib for all comers based on Niraparib data as an extrapolation, as Olaparib is the only available in Arab region?
So, yeah, it's true. Niraparib, it's not available, but for HRD negative, there is no data at all. No, there is no indication in HRD negative, according to the Paula, certainly.
I definitely agree with you. I wouldn't use it. Olaparib is the only one, which is, if you have that, that's the only one, then you have to use, but not in this setting. So how frequent you do CT scans during maintenance therapy? So when will you do a CT scan, and how often do you do CT scan for the patients?
Usually in ovarian tumors and even outside, even when they are on follow-up or on Avastin, we are doing personally every 4 months. And I follow also monthly with the tumor marker. And we are used to use the CA125 frequently.
Okay, that's wonderful. So I personally, me too, 3 to 4 months. And then next question, do you depend on CA125 alone in follow-up? Not exactly, actually. I think OBO5 was the trial where they shown that just CA125 alone does not help. So basically, you need to look into other things also.
Absolutely, absolutely. If the patient is asymptomatic with a CA125 stable, so it's a way to delay the scan, to wait every 4 months. Otherwise, if it's symptomatic and I have CA125, which is increasing, so I perform the scan before the planned time.
Yeah. So next question is, how frequent you do labs during follow-up with the Olaparib maintenance? So how often do you do blood test? Is it monthly or?
Monthly.
Yeah.
Even if we are looking to the hematologic toxicity, monthly is enough.
Yeah, it's the same thing. I do monthly also. All right. The last question here is, in case of platinum resistance ovarian cancer, what is the best treatment for the patient? So I know we have discussed all the platinum sensitive. Here is the platinum resistant. So what is your practice for a platinum resistant patient?
It's a big problem for the platinum resistant. Now we have ongoing trials with PARP inhibitor in refractory resistant platinum. We have even positive results in phase 2 trial, even with Olaparib, with Niraparib. As I show at the beginning, when they are platinum sensitive, all they are indicated regardless of BRCA and HRD. When they are platinum resistant, the choice is limited, but we have positive result now ongoing in the literature as a treatment, not at a maintenance, with PARP inhibitors.
That's right. Okay, thank you. So basically for my practice for the platinum resistance is a single agent chemotherapy. And usually after 3-4 lines of chemotherapy, then Olaparib can be given for those patients who have
absolutely.
disease. Okay, so
Faisal, there is a known indication of monotherapy with in 2nd and 3rd line in platinum resistant, like Hycompton, like Kylix, but also these drugs are not always available, like the Kylix, for instance.
Yes, and that was wonderful. Actually, I'm enjoying the discussion, but I think for the sake of time, we'll move on to our second bit of the presentation. So we have 2 more presentations, and quite interesting presentations, actually. So thank you, Dr. Joseph, and thank you, Dr. Wafa. So I'll move on to Dr. Basil Kefki, who's an assistant professor of surgical oncology at Mansoura University in Egypt. And he's going to talk about the fertility preservation in cervical cancer and there's a single center experience he's going to discuss with that. So Dr. Basil.
So good evening, everyone. And it's my honor always to be with the very nice group of the ABC Education with Dr. Samir Khatib, Dr. Fadi, Dr. Ihab, and everyone here. And thanks for the invitation. And today, when I learned that it will be about the updates in gynecological cancers, I tried to extend the slides a little bit to cover the ovarian endometrial very fast before going to cervical cancer to show how we can do this in the Arab world. What about the fertility preservation, this issue, which is more or less not very well done in ovarian cancers, in endometrial cancers, in cervical cancers. So we have the fertility sparing techniques and we have the fertility sparing indications. According to the pregnancy desire, according to the age, according to the cancer type, according to the stage of the disease, the treatment type, the type of surgery, the adjuvant treatment, the time available, and the likelihood of ovarian metastasis. For ovarian cancer, for example, we have just to do adnexal resection, what we call conservative surgery. For endometrial cancer, we do a hormonal treatment or just surgical resection of the lesion inside the endometrium or inside the uterine cavity. And in cervical cancer, we have the colonization, which are very good proportion of gynecologists can do the colonization. However, we have the simple and radical trachelectomy, which we don't have many training on that, I believe, and I can ask Dr. Ihab Brian about that. And we can do the oocyte preservations, ovarian tissue cryopreservations, in vitro maturation, the primordial and pre-enteral follicle cultures, uterine transplantation, and ovarian suppression by GnRH agonist therapy. For ovarian cancer, we have some indications.
Can you put it in slide view?
So
it's better.
We'll move
please.
to the second
Okay.
case.
I'm trying to do that. Sorry. I have to stop share first and then to put it in full mode. I have some problem in doing it in a full screen.
So shall Vanessa share it for you?
It's done now, no, but she does do that. I did it already. I'll do screen sharing. Sorry. Is it clear right now?
Excellent, excellent.
Yes, sorry for that. So in the ovarian cancer, we have some indications in the germ cell tumors, in the borderline tumors, and the stage 1 epithelial ovarian cancers, even if it's high grade. We have some sort of doing conservative surgery in it, like doing the adnexectomy. But again, I'm only here to share one slide. There is important note that fertility preservation ovarian cancer doesn't mean salpingioophorectomy. It means complete surgical staging. You should do omentectomy, you should do peritoneal staging, and you should. You are going to leave the other ovary and you are going to leave the uterus. In the few decades, we have to have biopsy from other ovary, but now the guidelines say no touch for the other ovary in fear for adhesions, but conservative surgery in ovarian cancer or ovarian tumors means a complete surgical staging, not just a salpingioophorectomy. This is only the note I want to share about ovarian cancer. For endometrial cancer, we do conservative surgery in young women seeking fertility, or in a very old woman with comorbidities precluding surgery, like the very obese, the old, the diabetic, cardiac hypertensive. I'm going to present some cases today, just tonight, case presentation from our real practice in Cairo and Egypt. This 37 years old single lady presented with abnormal uterine bleeding. She was divorced, she was preparing for new marriage, and then she has abnormal uterine bleeding. She had a hysteroscopic guided polyp removal on the 24th of August 2021, and the pathology showed it is endometrial carcinoma grade 2. This is the pathology. It's grade 2 endometrial carcinoma in such a poor lady. After revision of the pathology in another lab in Cairo, it said it is endometrial hyperplasia with no atypia. This is a totally different pathology. And this is another issue that we should discuss about the pathology reporting in all the region, not just in Egypt, about the revision and about the two experts review. We have another pathology revision, and it said it is EIN with evidence of coexisting low-grade mucosal endometrioid adenocarcinoma grade 1. So we have a grade 1 endometrioid adenocarcinoma, we have just hyperplasia, we have a grade 2 endometrioid adenocarcinoma. And the MRI of the pelvis after having removal of the polyp was free. This patient, I saw her when she was scheduled for hysterectomy. And we asked for a new hysteroscopy, and we did a pathology revision. Dr. Sami knows and Dr. Ihab that we do what we a big project with the International Society. This is a monthly tumor board where we do pathology revision and clinical decision review with experts from Berlin, from USA, from France, from Turkey, from Lebanon, all the friends. We do the pathology revision together. And then after the pathology revision, it was a grade 1 endometrioid adenocarcinoma. It wasn't a grade 2, so she was candidate for conservative treatment. And the new hysteroscope showed that there is no lesion inside. And so we just inserted a Mirena loop inside. This is a hormonal progesterone IUD, and adding the Megas, the progesterone oral. And then after that, we had some biopsies, and it was negative biopsies for the first time after 2 months. And then she has been followed after 3 months, and after 3 months, now we are following her for 6 months, and she is disease-free, and she is preparing for the marriage right now, and we hope she will conceive very early. So this is a decision where you do the tumor boards, you can change the decision, you can keep fertility for the patient, and we hope she will get pregnant in her future marriage, which will be in few weeks. Let's go to our topic today. It's about cervical cancer, where I have shown those slides before with Dr. Sami and with Dr. Ihab that we have a real problem with cervical cancer in the region with no established screening programs and no registry, no widespread vaccination. Now we have vaccination in Saudi Arabia, I believe in Emirates and Qatar. It was introduced in Libya, and we hope that it will be introduced so near in Egypt. There is no awareness about vaccination, and we always say it is a disease of sexually active female. We are conservative countries, and this is not true. So if we see few cases of cervical cancer, yes, around 1,320 cases in Egypt, according to the Globocan, we have mortality about 800 cases. This is more than half of the cases are coming in advanced stage and they die. We don't have a specialized radiologists in gynecological oncology. We have misinterpretation of the MRI, and we have the problem of the general gynecologists who are not well trained for doing conservative surgeries in the cervix. They don't see the cases. They are not interested in gynecological oncology, and they believe it is not a common disease. And we as oncosurgeons, we see very few early cases. We see every week cases of advanced stage 3 and stage 3B cervical cancer and beyond 2B. The oncosurgeons are not subspecialized in gynecological oncology, so they combine surgery with irradiation, they do salvage hysterectomies, they do laparoscopy, and it is contraindicated in the advanced cervical cancer right now, more or less contraindicated, I can see. And we have the problem of the irradiation with the long waiting lists for the external beam radiotherapy, very few brachytherapy machines. We have the problem of concomitant chemoradiotherapy. We can't apply it for our patient, and the neoadjuvant chemotherapy. We tried it to do the neoadjuvant chemotherapy followed by surgery, and it showed inferior results. Not all cases will respond to the chemotherapy. So the result of all this dilemma for the radiotherapy, for the gynecologists, for the oncosurgeons, that cervical cancer in Egypt is not a surgical disease. We meet every week in our center in Mansoura, 2 or 3 cases. Those cases are all beyond the stage 3, and we refer them for concomitant chemo or for definitive chemo irradiation. So what will happen if we meet an exceptional young cervical cancer patient in an early stage? This is a problem, really. I'll show 2 cases from our real practice in Mansoura. This case was a 20-year-old lady. She was married for 1 year. She didn't get pregnant. She was presented with contact bleeding. On examination, a 2-centimeter polyp was elicited, it was removed, and the pathology was adenocarcinoma of the cervix, and the revision of the pathology confirmed the pathology, and the post-operative after removal of the polyp, again, the MRI, the CT, the TVS were free. So this is the first pathology, endocervical adenocarcinoma, the usual type, and this is the CT post after removal of the polyp. This is the pelvic MRI after removal of the polyp, it is free, and this is the transvaginal ultrasound, and it is free too. The CT chest was normal, so she was presented for me at this stage, and I told her, I'm going to do for you a trachelectomy. She didn't hear about trachelectomy. She was either going for hysterectomy or for chemo irradiation. That's what we do. We started with pelvic lymph node dissection. We did the uterine artery ligation above the ureter, And then the uterus, after mobilization, it was mobilized from the pelvis and prepared of the interior and posterior spaces. Now this is the uterus was transected and removed totally upside down, and the blood supply now depending only on the ovarian vessels in the infundibulopelvic ligament. This is the uterus. And then we did a very easy trachelectomy with good margins, as you see. This is a frozen section which confirmed the free margins, the upper, the vaginal, and parametrial margins were all free. And then doing circulage around the uterine isthmus and the stenting of the uterine cavity to avoid stenosis, and re-anastomosing the uterine body with the vagina to put it back with the vagina. And the pathology was a grade adenocarcinoma, 2 centimeters in length with clear cell component. Oh, this is much more aggressive than what we have imagined from the primary pathology. The lymph nodes was free. It was a stage 1B1 at least. That's how we again introduced it in the tumor board, in the IGCS tumor board. And we asked about she should have chemotherapy. She want to get pregnant. What about oocyte preservation? She did an oocyte preservation and she finished her chemotherapy after oocyte preservation. And now we are waiting here to get pregnant for 2 or 3 months. If she didn't get pregnant, we are going to do assisted reproductive techniques to try her to get pregnant as fast as we can. But up till now, she is disease free. The other case, I met her in Cairo. She was a female patient. She was 28 years old. She was nulliparous. She was presented by vaginal bleeding. She had a TVS. It was a thick cervix, low anterior wall lesion 2 by 1 centimeter, no related infiltrations, and the post-contrast MRI show a mass which was 0.9 by 2 centimeter with normal thickness. This is the biopsies, and this is the MRI and the histopathology report, and it shows a well-differentiated adenocarcinoma. Again, it is not squamous. The post cases are adenocarcinoma. And the TVS, we had the small mass 2 by 1 centimeter, and the MRI shows the same size. So I saw her at this moment. Really, she was in a total mess. She was scheduled for hysterectomy. She is not married yet. And then the doctors were afraid in the big institute to do a hysterectomy for a virgin, not a virgin female, but she wasn't married before. And then they referred her for concomitant definitive chemoradiation, which would for sure affect her fertility. And the doctors of the oncology said, no, we are not going to do. This is an early case. She should go for more conservative surgery, which is not colonization for sure. So I met her at this step and I told her we can do trachelectomy. It was the first time she heard about trachelectomy really. And I told her that I'm not an expert in trachelectomy. I have been assisting my professor in Tokyo 10 or 8 years ago for many cases, but from the moment I was in Egypt, I performed only the first case, so it was my second case at this moment. And I told her by very clear words, I am not an expert in doing trachelectomy. I saw it several times in Tokyo, but I performed it alone one time, and you will be the second case. If you find anyone else in Egypt, either in Upper Egypt or Lower Egypt, in Cairo, in any place, who has performed a longer or a larger series, please go directly with him. And really, she went away for 1 or 2 weeks, and then she returned. No one really had done a trachelectomy before. I'm not sure about that. And I want you to do the trachelectomy. So we did an iliac lymphadenectomy, sending the frozen section, again, like the first case. We did a radical trachelectomy, including the cervix, the upper third of the vagina, and parametrium with circulage and resuturing. It was the same technique. This is the left external iliac artery. This preparation of the space with parametrium. This, again, the uterus after transection and removing the uterus upside, depending on the ovarian vessels only. And this after anastomosis and circulage after removal of the uterus. The paraffin results were well-differentiated endocervical adenocarcinoma, gastric type, pattern P, stromal invasion, free all 10 right and iliac lymph nodes, and the depth of stromal invasion was 4 millimeter, no lymphovascular emboli. The distal vaginal safety margin showed a small foci of atypical gland consistent with invasion of distal vaginal margin. They were detected in the frozen section, exhausted in the paraffin section. It was a 1B1 again lesion. This is the pathology. It was a FIGO stage 1B1 lesion. And so again, we had a dilemma. This is a gastric type. This is very aggressive. This is we introduced it in the IGCS project. Here you can see Robert Coleman. Robert Coleman is the head of International Gynecological Cancer Society. He's a very well-known oncologist. You can see Sarah Nassar from the PARCO. So you have many people from Egypt, from Jordan, from whatever, and we introduced the case, Jahid Suhouli, and we revised the pathology. And they asked it to do the P16 to be sure it is a gastric type, is it aggressive type? But after doing the IHC for the P16, it was usual type cervical adenocarcinoma HPV associated usual type, so it wasn't the gastric aggressive type. And we did a PET CT scan according to the recommendation of the panel, and it was totally free. We had nothing. So she just went on follow-up. She has been on follow-up now for 1 year. She has been operated last June, and now she is 1 year. She had 2 or 3 MRI after the surgery. She is still disease-free. She hasn't got married yet, and we are waiting here to get married to see if she can get pregnant or not. This is just the message that you can sometimes keep the fertility for young females. Don't rush for doing hysterectomy. If you don't know, please refer to someone, search, and be honest with your patient and tell her that she has the options of conserving her uterus. And then you can do it in our low resources countries. You can do the conservative surgeries and conservative maneuvers either in the cervix or in the endometrium. And I'd like to invite all of you to join us in Cairo on the 22nd and 23rd of September with the EGOS, the Egyptian Gynecological Society meeting, the second meeting. It's endorsed by EMAC, and it is ESGO accredited meeting. And thank you.
Thank you very much, Dr. Bassel. This was nice, actually. So I agree with you, actually. We are not doing a lot of fertility preservation. And in fact, currently we are doing a study for those, I'm a medical oncologist, so we do chemotherapy, and similarly, we don't look into the fertility part of it. So currently I'm doing a study to find out if we are doing the, if the oncologist is concerned about the oncofertility with the chemotherapy or not. So, but this is an interesting topic, actually. So again, we have one more talk, and then you have discussion after that. So our next topic is surveillance after the treatment for endometrial cancer. So Dr. Ihab Al-Rayyan is a consultant of Gynae Oncology and colposcopy at King Hussein Medical Center in Jordan. So Dr. Ihab will talk about the endometrial cancer surveillance after finishing the treatment. Dr. Ihab.
Good evening, and thank you for this invitation. Thanks for Dr. Sami, for Dr. Fadi, Dr. Bassel, and everyone. We already presented this presentation a few months ago at Egypt with Dr. Bassel, but since it is a short notice, so we had no time to prepare for another presentation. We look here at the follow-up for patients with endometrial cancer. As we know, endometrial cancer is the most common gynae cancers, and among all solid tumors, the incidence is increased, as well as death rates. The incidence increased by less than 1% per year, and death rate as well. It increased 20% since 1999. But fortunately, most patients with endometrial cancer, they survive their initial diagnosis because they are diagnosed at an early stage. And among all gynae cancers, there is a large group of patients who survive endometrial cancer and need a follow-up. And it is only after breast cancer regarding the survivals. But unfortunately, there is lack of clear evidence about the best practice in follow-up for those patients. And here we are going to review the recommendation for post-treatment follow-up and surveillance after primary diagnosis and treatment. So our main aim here is to detect early recurrence of the disease. And we are going to discuss the frequency of our follow-up visits and who's going to perform the visits, the follow-up, and the role of tumor marker radiology and vaginal cytology, plus another health issues related to endometrial cancer. Looking for the pattern of recurrence, most of our patients with endometrial cancer, they are recurred in the first 3 years after being treated. And most common sites of recurrence are either vaginal vault or in the pelvis or abdomen. And the rate of distribution is equally between local recurrence or distal metastasis. Though patients who received radiotherapy, they have a lower incidence of recurrence compared to those who received no radiotherapy. And based on systemic review of 16 observational studies, most patients, more than 70% of patients with endometrial cancer recurrences, they are associated with symptoms. And signs and symptoms suggestive of recurrence, including vaginal bleeding, abnormal abdominal or pelvic pain, a persistent cough, vaginal discharge, and change in both bowel or bladder habits. It is important here to just notice that all the studies showed that there is no survival difference was detected between patients who were symptomatic and asymptomatic at the time of their recurrences. In one study, they studied the modalities of picking patients with recurrence and mainly with those asymptomatic patients. And they managed to detect the recurrence in asymptomatic patients through physical examination up to 1/3 of patients, through ultrasound examination up to 13%, using the CT scans in up to 20%, chest X-ray 14%, and using the tumor marker CA125 in 15%, while using the vaginal vault cytology in up to 4%. So the surveillance and follow-up patient with treated for endometrial cancer will depend mainly on symptoms presented by the patient, as well as on a proper examination and performing biopsies when indicated. Because early detection of recurrence, especially at the vagina, is associated with a high survival. And this is illustrated in the PARP trial, in which about 90% of patients detected with vaginal vault recurrence, they will have a complete response after their being diagnosed. For the surveillance, there is no high quality evidence that any specific post-treatment surveillance can provide a better outcome for those patients. And in absence of these data, we just depend on the guidelines from the NCC and the CGO guidelines, which depend mainly on symptoms and physical examination, which is performed every 3 to 6 months for up to 2 or 3 years, then every 6 months up to 5 years. And though the frequency of this examination depends on the risk of persistent or recurrence for patients with endometrial cancer, as well as we need to investigate more about that and concentrate about the genetic counseling, especially those patients with a family history suggestive of Lynch syndrome, and those patients with microsatellite instability on tumor screening. Again, there is no published prospective studies evaluating the role of surveillance in patients with endometrial cancer. In one prospective randomized trial called the TOTEM study, which was presented in the ASCO 2021 annual meeting, and they compared intensive versus minimalized surveillance for patients with endometrial cancer. It involved patients with more than 18 years of age, with a histopathology showed endometrial cancer with all stages, without any residual tumor, after being surgically treated, with the absence of any other secondary neoplasm, without any hereditary symptoms. So they subdivide those patients into 2 groups, group with intensive follow-up for 5 years and patients with minimalized follow-up. And each group is subdivided into patients with high risk and low risk. So they started with intensive follow-up for patients with high risk disease, which involves stage 1A with poorly differentiation or more than 1B. And they did a clinical examination and CA125 performed every 4 months for up to 3 years. Plus performing ultrasound and a yearly CT scan and pap smear. And they compared it for patients with low risk of recurrence. And they had, again, a clinical examination every 4 months up to 2 years with the yearly pap smear and CT scan for another 2 years. The other group with minimalized follow-up, those with high risk, they had only clinical examination every 4 months for 2 years. Then after that, every 6 months with yearly CT scan for the chest, abdomen, and pelvis for 2 years. Patient with low risk, with minimalized follow-up, they had only clinical examination. So what they found in the TOTEM study, intensive follow-up in those patients did not improve the overall survival, even in those patients with high risk. And there was no difference in relapse-free survival, health-related quality of life, and compliance with the patient. And the Spanish study, they studied the efficiency of endometrial cancer follow-up protocols, and they had the question about it is time to change our practice in following those patients. The aim of the study was to analyze the relapse rate and patterns in patients with endometrial cancer, and their aim was to evaluate the effectiveness of the current follow-up procedures regarding the overall survival. It was a retrospective descriptive study performed in Spain between the year 2005 and 2014, and their data showed that 10% they had a recurrence rate. 66% of those patients, they had a recurrence in the first 2 years, 80% in the first 3 years. About 42% of those patients, they had a distal metastasis compared to 41% with a local regional recurrence. And 42% of those patients diagnosed with recurrence, they were symptomatic. So most of the patients, they were asymptomatic at the time of diagnosis for the recurrence. Again, they studied the way of detecting the recurrence. They managed to pick the recurrence through symptoms and physical examination in more than half of those patients. Tumor marker was managed to pick the recurrence in about 1/3 of the patient, CT scan about 10%, and using the vaginal wall cytology in only 6%. And there is no difference in global survival was detected between patients who were symptomatic or asymptomatic at the time of relapse. So in summary, the role of tumor markers, CA125, its use, it varies across institution. And its benefit in surveillance for asymptomatic patients is still controversial. So the NCC guidelines, they recommend its use only if it is initially elevated before the treatment, while the SGO guidelines, they don't use it routinely for follow-up unless it is clinically indicated. Regarding the vaginal cytology, the data suggests that it is an ineffective way in detecting the recurrence with low sensitivity. And in one study involving more than 400 patients, no case of vaginal vault recurrence were detected based on isolated abnormal cytology. So both the CGO and the NCC guidelines, they recommend against the use of vaginal wall cytology in following up patients with endometrial cancer. The role of imaging as well, as we know, we are performing a lot of CT scan with the risk of radiation exposure and having second malignancies. And again, even the use of routine chest radiography in asymptomatic patients, it is not supported by evidence. So the SGO guidelines regarding they advise that imaging can be used only in symptomatic patients on patient with abnormal findings on physical examination. While the NCC guidelines in 2022, they subdivided the use of radiology according to the stage of the disease. Patient with early stage 1 and 2, the images can be performed if it is clinically indicated for symptomatic patients, while patient with advanced stage 3 and 4 endometrial cancer, CT is an optional recommendation every 6 months for up to 3 years, then every 6 to 1 year for additional 2 years. The use of the PET-CT for routine screening for recurrence is not well studied. It is a costly modality for imaging, though it has a high sensitivity and specificity in diagnosis of recurrence, and it is used only for patients with suspected recurrent disease. In meta-analysis of 11 studies, it supports the use of PET-CT as another modality for evaluating suspected cases of suspected cases of recurrence, especially if it is performed with the CT scan. In reviewing the NCC guidelines, they advise performing physical examination every 3 to 6 months for up to 2 or 3 years, then every 6 months for up to 5 years. The role of tumor BRCA125, it is recommended if it is initially elevated. The use of imaging is indicated only if it is clinically indicated, and they have a special attention for changing the lifestyle and looking for other preventive health issues related to endometrial cancer. As we know, those patients with endometrial cancer, they had a bad shape, and they are obese, hypertensive, diabetic, and they may die from other comorbidities not related directly to endometrial cancer, especially ischemic heart disease. So we need to focus more on healthy lifestyle behavior for those patients, looking for immunization and prevention of infection, cardiovascular disease, risk assessment, sexual issues, especially for patients who receive radiotherapy to the pelvis, and not ignoring the psychological impact as well. Sorry. It is interesting to look for the Canadian guidelines. So they mentioned that all patients with endometrial cancer should be advised to contact their physician earlier than scheduled if they have new symptoms. And these symptoms are vaginal bleeding, vaginal discharge, change in bowel or bladder habit, developing of abdominal distension, persistent hair fluid not related to upper respiratory tract infection, weight loss, lethargy, pain, or headache. And again, they looked for the stage of the disease. So patient with stage 1A disease confirmed to the endometrium without presence of myometrial invasion, they recommend those patients to be discharged immediately after their first follow-up visit without any need for follow-up. Patient with stage 1A, 1B disease, but low risk for recurrence, they can be followed by their family physician or general gynecologist every 6 months for 5 years, and then discharge after that. Patients with high risk or high stage disease, or those with high risk of recurrence, it's better to be followed by a oncologist every 3 months for the first 3 years, and every 6 months for total 5 years, and discharge after that if had no relapse. Again, the Canadian guidelines follow-up depend mainly on proper focusing on symptoms with a proper history from the patient, performing a proper physical examination that should include pelvic bimanual specular examination, And as this can detect up to 80% for patients with recurrence, with no imaging is suggested for a routine follow-up visit. And for sure, pap smear is not part of a routine screening for recurrence for endometrial cancer. And thank you. This was just a short and brief review for the recommendation for screening and surveillance for patients with endometrial cancer.
Thank you very much, Dr. Ihab, for a nice review about how to follow up the patient with the endometrial cancer. So now we have time for discussion, and we will open the floor for anyone to ask the questions. But before I start asking questions from Dr. Basil and Dr. Ihab, we had a few questions about ovarian cancer posted after we close the session. So I'll just briefly go through it first. So basically most of our attendees are asking about the platinum-resistant cancer. So what chemotherapy? So chemotherapy, we use single agent, mostly either liposomal doxorubicin, topotecan, gemcitabine. Hormones can be used in these patients, depending on how the patient is. Trabectedin can be used if it is available in your hospital. Patient who have developed febrile neutropenia on PARP inhibitors, will you reduce the dose? Yes, we do reduce the dose, and there's the guidelines how to reduce the dose. And what is the single agent, best single agent in platinum-resistant chemotherapy? Actually, there's no best single agent chemotherapy, but you can select the best patient, whichever it is. There's one question about the patient with a heart failure in platinum-resistant. So depending on how much is the heart failure, if the patient is fit, they can have any chemotherapy. I would avoid doxorubicin-based chemotherapy, but they can have, but if the heart failure is not stable, then it will be difficult to give any chemotherapy. So this is about ovarian cancer, and now we have time to discuss the with Dr. Basil and Dr. Ihab about the fertility preservation and then surveillance in the endometrial cancer. So any question anyone want to ask? Yeah. Who and how frequent should we follow the endometrial cancer? Dr. Ihab.
Sorry, what's the question again?
Question is, who should follow up these patients and how frequent we should follow patient with endometrial cancer? They have not mentioned the stage, but there is a generic question. The patient is treated, yeah.
I think well, we need to start with the assessment, the risk of recurrence. If the patient is an early stage, if there is no myometrial invasion, the follow-up visits should be long. So we can just do every 6 months for 2 to 3 years. But those patients with high risk for recurrence, those with a bad histology or type 2 endometrial cancer, or those with high stage, it's better to be followed every 3 months by a gynecologist. So I think it is an it will be individualized according to the type of the disease, to the stage of the disease, and the type of the pathology of the disease as well.
Right. So if I summarize, you mentioned the stage 1A patient can be discharged.
Those 1A without myometrial invasion.
Right. Okay. And who are the patients who can be followed up by their GP or by the
those with those patients with 1A or 1B with the presence of myometrial invasion.
Mm-hmm.
Those can be followed up by the general physician as their incidence of recurrence are low. But patients with advanced stage, patients with high-risk disease like serous papillary tumor or those with poorly differentiated tumor, it's better to be, it should be followed by a gynecologist with close surveillance and close follow-up visits. The most important thing that we depend mainly on radiology, but we can pick more recurrence if we physically examine our patient or if we listen more carefully about the symptoms of those patients rather than performing a radiology or performing a blood test.
Actually, the next question is the same. So what they are asking is, do we need to do a CT scan in follow-up for stage 3 and above disease, so more advanced disease, or do you rely on symptoms? So would you routinely do a CT scan, or is it only when they get symptoms you'll do a CT scan?
Again, it is optional. Personally, I prefer to perform a CT scan every 6 months for the first 2 years. And after that, we can extend it every 1 year. But it is an optional as well. And I think we should discuss it with the patient and discuss the risk of radiological effect on those patients as well.
And so the next question is about the same. By doing all those, do we have any evidence that it improves the overall survival, or does it have any impact on overall survival?
No, all the data suggests that for our patient, for asymptomatic patient, there is no improvement in overall survival. Either we are performing close monitoring or not. So we need, I think, the best thing, we need just to focus on symptoms, to focus on proper physical examination rather than focusing on radiology.
Excellent, thank you. And Dr. Bassel, if I can ask you a question. So which patient would you select for fertility preservation in cervical cancer? Is it just based on the early stage disease, or there are other characteristics? Because we, even in Saudi Arabia, it's extremely rare to see a patient who had trachelectomy. Almost all these patients have they present in advanced stages. So what is the criteria for those patients where we can preserve the fertility?
Yep. So for sure, we can do fertility sparing surgery for any case who is less than stage 1B2. So you can do it in 1A, 1A1, 1A2, and 1B1 at least. For either squamous or for adenocarcinoma, it doesn't differ. Again, you know, we have the CDLS criteria. So if we don't have a lymphovascular invasion, if we don't have, of course, a node positive disease is not stage 1, and invasion of less than third is a stroma, the depth of invasion, and the lymphovascular emboli, and the grading of the disease itself. So if I'm not fulfilling the CDLS criteria, if I have an early stage just up till 1B1, I can do a trachelectomy. Again, it's the same in Saudi Arabia, like in Egypt, that we see very few cases of early cervical cancer. But really now I believe more and more awareness is going on. And so I believe we are going to see more cases. Last week I saw a case, but she was already, she has completed her family, so it wasn't logic to do a trachelectomy for her, but she was a stage 1B1 cervical cancer. So it's for either adeno or squamous, stage 1B1, and not exceeding the CDLS criteria of the high risk of the risk stratification of cervical cancer.
Thank you. Another other question would be, you suggested about the HPV vaccination. We have actually recently started HPV vaccination in Saudi Arabia. Yes. So do you think it should be for all the girls above 9 years or 10 years old? I worked in UK, so we were giving it routinely to any girl who's above 9. So do you think is it the same thing here we should do? Is it in other words, cost effective to do this sort of vaccination program? And is it culturally, do you think it's some sort of thing which is acceptable, or do you think it will have some sort of a dilemma with it? So these are a lot of questions I'm asking because a lot of women come to me and ask these questions. So yes. I thought if you have any experience, please.
So for cost effectiveness, I believe that according to the literature and according to the evidence after long years of follow-up, it's cost effective. It saves lives, it decreases the incidence of cervical cancer, and it prevents cancers. And as long as I have a preventable cancer, it is not logic that I wouldn't prevent it. So from cost effectiveness, it's cost effective worldwide. For Saudi Arabia, for example, or for countries which can afford that, I believe it should be incorporated. Again, I vaccinated my girls. I have 2 girls, and I vaccinated them already by HPV. They have the full doses. And I believe I know the culture and the disease of multiple sexual females and all this dilemma. I'm not going to tackle in depth in that. But again, I am protecting my girls. My role is to protect my girls. I learn them and I teach them, and then I have to protect them. Even if they are very, very straight, I don't guarantee their partners. In Egypt, for example, we have many partners who live away from Egypt, and so you don't know, they can be married, they can have multiple sexual partners, and they can transmit the disease for their females. We are speaking now about even non-sexual modes of transmission, about the contact. So it's again, the country should say if it is a health cost, this is the health economics. I believe now we can speak about, for example, mass vaccination in Egypt after all this economic crisis and the COVID and then the wars, and you have economic crisis. So we can postpone, but we can't say we don't need it. We can postpone vaccination. But my mission is that I'm doing now, and I believe Dr. Sami is following that, is that we are raising awareness. Those who can afford, everyone should know that there is a vaccine that protects against cervical cancer. And then you can choose whether to have the vaccine.
If you allow me, Dr. Basil.
Yes.
If you allow me, Dr. Basil, I just want to say the vaccination for cervical cancer or for the HPV, it's not only for cervical cancer. It can prevent another 6 types of HPV-related cancers, which is the vulva, the vaginal cancer, the anal, penile, oropharyngeal cancer. So it can help not only cervical cancer. It's very effective vaccine, and the most important thing, it can prevent cervical cancer by 100% if we perform the vaccine and performing a proper screening. We are talking about a number reaching 100%.
Mm-hmm. Exactly. And we know the policy of WHO by 2030 that there should not be cervical cancer in the world by 2030. This is the WHO vision for cervical cancer prevention. So for me, again, I can't say, according to the economic situation that's happening nowadays in the worldwide, in Egypt, in Jordan, I can't say that the country must implement now the vaccination program, but they should study that. I'm not the one responsible for that. But my mission is that every woman, because even doctors, even our colleagues, even some oncologists don't know anything about the HPV vaccination and how it prevents that. So we should raise awareness. The community should know. The community should be offered that. If someone wants to take the vaccine, the road or the pathway should be easy and should be well known for everyone. And then we go for the upper authorities, for the health council, and we say, please see it. If you can afford, please do it. And I believe it's going to be implemented in just like in 1 or 2 years. I believe that in Egypt.
Yes, thank you. So the question is actually, someone asked the question about the HPV vaccination. You mentioned that can prevent the nasopharyngeal carcinoma. So how about vaccinating boys then? Because the nasopharyngeal carcinoma is quite common in men rather than girls. So shall we be vaccinating boys, do you think?
I believe boys should be vaccinated too, because they are the mode of transmission. They are mostly the mode of transmission of HPV to the girls. So just to protect the partners and to protect themselves. I know again that the anal cancers and rectal cancers for the homosexual are much more common. And we have all this now. I don't want to go to political issues, but the world is changing. And there is much more speaking and speech about the LGB and all of that hassle. So it will be increased. It will be increased and worldwide. And what happens in the world will be reflected in the Arab world as well. So to protect the partners, to protect the partners.
Yeah, they currently don't know evidence to vaccinate men actually or boys. It's only for women for the time. So there's a couple of more questions and then, sorry, Basil, you were saying something.
Yes. No. We can give it for boys. We can give it for boys. It is already. It can be given for boys to protect them from, especially with the increase of the oral sex and all of that. So it can be given for boys. But first, let's vaccinate the girls and then go to the next step.
Yes. Yeah. Okay. So just a couple of more questions for endometrial cancer follow-up. Does the medical oncologist have any role in follow-up? So can medical oncologists follow up the patient with endometrial cancer? Just quickly, Dr. Ihab, what do you think? Medical oncologists have any role in follow-up, or it should be only gynecologist?
I think if our patients need chemotherapy or if they are on hormonal therapy, they should be initially managed or followed by the medical oncology during the time of receiving medical or hormonal therapy. I'm not sure they are capable of performing a proper physical examination, I mean vaginal examination or pelvic examination for patients with endometrial cancer. But during their, while they're providing their services for chemotherapy or hormonal therapy, I think, yes, they can follow those patients. But once they finish the cycles of chemotherapy, it's better to return them back to their gynecologist or gynecologist.
I agree, actually. So what we do is when we finish with chemotherapy, we share the follow-up with the gynecologist. So
exactly.
And the last question, actually, there's one more question somebody asked. So the girl who have a yolk sac germ cell tumor refusing surgery, what is the solution? Well, the solution is chemotherapy, actually. Germ cell tumor is quite sensitive to chemotherapy. So I would give chemotherapy, and surgery is the treatment, but we can cure actually just with chemotherapy also. But again, we need to convince the patient it's an aggressive but curative cancer. Okay, that's the last question here. Do we need local or vaginal examination and follow-up of uterine cancer?
I don't think that the question is, do we need? What we should say, we should perform. We should perform proper physical examination. We should perform it.
So it's must.
Can I need just add a comment?
Please.
The first quiz, they mentioned that we are starting the pap smear at the age of 21. And actually, all the new recommendation, I mean, the American Cancer Society, the British, even the Australian, now they are starting the screening for pap smear at the age of 25, not the age of 21, up to the age of 65. So it's not now 21, it's 25.
Excellent. Thank you very much.
Excellent. Thank you for the clarification.
Yes, thank you very much. So, okay, so I am really enjoying actually this debate, but I think we are just over the time. So thank you very much for everyone who has presented, Dr. Wafa, Dr. Joseph, Dr. Basil, Dr. Ihab.
Thank you, everyone.
You gave us.
It was our pleasure to join you.
Okay. And
Okay,
Dr. Sam, Dr. Sami, Dr. Fadil.
Okay, so thank you, Dr. Faisal Azam.
Excellent. Yeah, thank you very much. And
consultant medical oncologist at Fahd Specialty Hospital in Dammam, Saudi Arabia. Thank you for running very well this session. Thank you for all our speakers. Just I would like to say to all our participants that July and August will be off of activities, and we will restart inshallah on September. So thank you all. Dear Dr. Fadi, the floor is yours.
Thank you. It was really excellent. I will not repeat what Sami said. Faisal, thank you very much for all our speakers, and thank you, Sciences Po, for managing this this activity. Thank you for the audience for being with us. Just please, if you need any information or you need the certification, please contact us. Thank you very much, and see you in 2 months.
Okay.
Bye bye. Salam.
Bye. Good evening. Bye.
Thank you. Good night.
bye.
Thank you.